medical emergencies is kind of a broad title for this class. We're going to kind of touch on a lot of different things, so be prepared for that. We're going to, like I said, touch on several different, again, medical emergencies. So, we'll talk about heart attacks and strokes and high and low blood sugar, altered mental status, several different things. So it's one of those that kind of just helps prime you for some of the other chapters that we're going to get into. That's going to get into each one of those a little bit more specifically. And then body systems kind of helps you understand how those emergencies are happening or why those issues are happening in the body. Does anybody have any questions from last week or anything in general before we start? None. All right. All right, so like I said, several things we're going to talk about here: angina pectoris, heart attack, dyspnea, asthma, stroke, hypoglycemia, and diabetic coma, general abdominal pain. We'll kind of get into a couple different reasons why we have abdominal pain. Like I said, there's not a ton of things that we're going to be able to do for the actual medical patient. So the patient's experiencing some type of general medical emergency, as far as real definitive care, you know what I mean. But there are a lot of options that we have also within our scope of practice to be able to do that. So it's just one of those things where we have to be cautious about going over that scope of practice and doing things for people. We're going to talk a little bit about giving people medicine and different things in some of these, and we'll try to make sure that you understand, how and when we can do that. So next few slides, we're going to touch on patient assessment. Okay. Again, I told you it's one of the most important things that we have going for us. It really is our bread and butter. It's what we need to be good at. And this is some of obviously several of these things we're going to talk about. We're going to talk about how it plays into that. We talked about in patient assessment, specifically on the medical side, picking that lane, right? So we have to pick a lane. Well, we're going to talk about the lanes tonight. So several of the things we're going to talk about tonight are the things that we're going to actually be working on treating. So patient assessment, again, in medical emergencies, like we talked about before, you really want to make sure that we review dispatch information as soon as, as often as we can. That way we try to get the most up-to-date and reliable information about what's going on. And we can help to, again, start our treatment plan, as early as possible. Again, scene safety is paramount. We got to make sure that we are always looking around, paying attention, don't get tunnel vision on our patient, or at least have people there with you so that you can focus on the patient and somebody can be watching your back and looking out for those things. We mentioned talking about trying to form the general impression of the patient or getting that chief complaint, and those are it's a big deal. We really want to make sure that we try to get a good, firm understanding of what's going on there. Then, of course, we're going right into checking for responsiveness, right? Looking for that level of consciousness. If they're awake and alert and everything else, want to introduce ourselves, check our ABCs. Obviously, like I said, if the patient's sitting up looking and talking to you, they probably have all three. Okay. And again, acknowledging that chief complaint, trying to make sure that we have a good idea of what that is. And if, again, hopefully they can tell us, and if not, we need to try to ascertain that from hopefully somebody nearby, or maybe from dispatch. If dispatch was talking to them at one point and now they're not talking, we try to get as much information from dispatch about what they told them. Or a caller. Sometimes it's a third party where, elderly grandfather has called the son and told the son he feels bad, his chest hurts, and he has pain in his shoulder and all this other stuff, and hangs up with the son. Son calls 911, says, "Hey, my dad's having chest pain. I need you guys to send an ambulance over there." And we get there, and grandpa's not conscious anymore. So we try to get some of that third party information that as best we can. Like we talked about before, also obtaining that medical history, doing that sample history, signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the incident are all, we need to try to get that, as soon as we can, so we can help to kind of formulate a little bit of a picture about what's going on here, what's been happening with the patient. Of course, vital signs, we're going to get that, right? Blood pressure, pulse, heart rate, and skin color and condition. And then, of course, reassessment, right? Always reassuring our patient as well, especially you have some that are really anxious or worried, scared. So it's important for us to get that information. I mean, get them in a position where we can make them feel, like everything's going to be okay. And, even if it is very serious, we still want to, ensure them that we're, take care of them. We're going to get them to a higher level of care very quickly, and that we are going to do everything we can to make sure that they get a good level of care. So again, like I said, we're going to talk about several different general medical conditions. A lot of things have very similar signs and symptoms. Okay, so it does take a little bit of practice. It does take some more reading later on after class. After you get done with this class and all that, you have to kind of still, you still have to read up on things, and especially when you get into on the job training where you're actually responding to calls and going to people's houses and dealing with stuff and watching other EMTs and paramedics and first responders, actually do these things. It's important to learn from them and learn from those experiences, because like I said, to be able to really define or draw a line in between some of these things. So one of those is altered mental status, and again, a very broad term, okay? And that's one of those, that's kind of with this scope of practice at the first responder level, we essentially are kind of generalized, okay? We aren't able to treat really deeply, right? So we aren't able to give a lot of we're not able to give a lot of medicine. We're not able to do a lot of invasive techniques and procedures, for the patient. So we're not sticking stuff down their throat. We're not, giving them medicine or doing IVs and all sorts of stuff like that. So, but again, like I said, what we're really good at is getting the information, and then, providing that base level of care, to get them, in a position where it's easier for the other higher levels to be able to do their job. Okay. So altered mental status generally presents kind of like it says there, a sudden or gradual decrease in the patient's level of responsiveness. So it could be either or, just depends on what's going on with them. But remember that APU scale. So how are we determining their level of consciousness? And that would be through that scale. So are they alert? Are they up looking at you, talking to you? Are they only alert whenever you shout their name or yell real loud or something like that? Are they alert only whenever you provide a little bit of painful stimulus? Or are they just completely unresponsive? They don't respond to any of that painful verbal or anything, right? So then they would be unresponsive. So, of course, we want to see what that initial level of consciousness is, and then any change in that. So if they are, awake and talking, no problem, and then they start to deteriorate, to where they're confused and they're not able to, respond back to you very well. So we want to obviously note those types of changes, either, from bottom to top or top to bottom, whether or not they're getting better or worse. So altered mental status, again, it's a very general term. Like I said, it has several potential causes, and those several things here we'll read off. Head injury. So, if you get in a car accident, fall off a ladder, in any number of things, slip and fall, and you hit your head, or some type of degenerative, head injury, something that happened due to some type of illness. Shock. So if we have, shock, the textbook version or definition of shock is inadequate tissue perfusion. And so if we have inadequate tissue perfusion to several areas of the body, or specifically to the brain, then we're going to have some type of altered mental status. Okay. So shock, there's multiple different types of shock, and we'll get into that later, but there are, that's essentially the tissues in the body are not getting adequate blood flow, oxygenated blood flow. So decreased level of oxygen in the brain for a number of reasons. Again, if we're having some type of breathing problem, and we're just having that decreased level of oxygen, we're in a oxygen deficient atmosphere. So if we are, somewhere where there's a lot of, you may have a patient who's trying to commit suicide by, CO2 poison or something like that, or carbon monoxide poison, by sitting in their car in a garage, that would be a decreased level of oxygen to the brain type scenario, right? Stroke. So if we have some type of blockage or thrombus, which is just a buildup in that vessel, or something gets lodged in a vessel in the brain, and potentially causes that blood flow, that oxygenated blood flow to the brain from getting to where it needs to go. And so you could have some type of altered mental status from them having a stroke. Slow heart rate. Again, the blood's just not flowing very fast enough to get that oxygenated blood to the brain, and so that might cause a delay in reactionary, type, maybe some sluggishness, things like that. High fever. Obviously, the brain is just getting too hot. Okay. In babies, we refer to that as febrile seizures. We'll talk about that a little bit more here in a little bit. I got a good story for that. Some other ones are infection. So as infection sets in to different parts of the body or the brain, it just could affect different parts. Like I said, different parts of those body systems. And so just like we talked about the heart being a potential issue, or the lungs being a potential issue with breathing and causing altered mental status, that infection may be the actual root cause of some of those as well. Poisoning, obviously. So if someone's, been poisoned, or just eat something that they shouldn't, or ingest something that they shouldn't, then you obviously can have some type of altered mental status where they're seeing things, they're hallucinating, they just may be, really lethargic and weak, and they're just not able to respond well to you. Low level blood glucose, so hypoglycemia. That again is one of those that's pretty consistent with an altered mental status. It's pretty common for that to happen. You're sugar drunk, that's another term for it, where they don't have enough sugar in their bloodstream, essentially, and the brain doesn't work well. It doesn't work right, and it makes them act almost drunk and pretty out of it. So insulin reaction, typically where somebody who is insulin dependent takes their insulin but does not eat with it. So that usually results in the same, very similar type of condition as hypoglycemia. Psychiatric condition, so just any number of psychiatric conditions may have different types of altered mental status. So, again, like I said, not a whole lot I can do for their brain and all these other things, right? We can't just get in there and perform brain surgery and fix the problem. So, we have to kind of keep it simple, maintain the patient's ABCs, try to, maintain normal body temperature. If they're really hot, so if it is something where they're having a fever, we try to keep them cool. And try to bring that temperature down if we can. Obviously, if it's the other way around, we want to keep them warm. But irregardless, if they're not able to think well for themselves or not able to respond well for themselves, we want to make sure we keep them out of harm's way. So we don't want them, if they are walking around, we don't want them stumbling around, falling down, hurting themselves even more, right? So that's a big part of it. If the patient's unconscious does not sustain trauma, place the patient in a recovery position and use an airway adjunct if needed. Like I said, it may be one of those where they're breathing just fine, they have good blood pressure, heart rate, and it just could be that they have something else, have something going on in their brain, and we just can't diagnose it, and there's nothing really pointing at it. So we just try to maintain those ABCs and make sure they're in a position of comfort, and be ready to act in case any of that sort of changes, right? So another one of those is seizures. The seizures, several different types of seizures out there, and they, generally it's an electrical problem in the brain. So it just, the brain synapses are typically aren't firing correctly, and kind of more of a sporadic type pattern. And so the body again has to do what the brain tells it to do, right? And once it does that, so once it gets disrupted like that, then the body doesn't know what to do. So sometimes you have, the shaking movements that you may see in seizure patients. It could be the whole body, it could just be the arms contractured up. And there's other ones generalized, this is a generalized seizure, but some other ones you may have where they're just really kind of staring off in space and, just kind of looking around, and their eyes might be fluttering a little bit or something like that. Or they just basically just like they're asleep, but you can't wake them up. But they're maybe panting, breathing heavily, stuff like that. So those are pretty indicative of that. Usually lasts 1 to 2 minutes. The time after the seizure, so after they have a seizure and they are usually somewhat unconscious, then we refer to that as the post-ictal state. Post-ictal state. So, if you're ever given that report and you're there with the patient and they had a seizure, you watch the seizure, or they say, hey, yeah, they just had a seizure a minute ago, and they're kind of relaxed now, but they're kind of unconscious, semi-conscious, we refer to that as the post-ictal state. So generalized seizures, again, caused by sudden high fever, are called febrile seizures. Normally we see this in infants and children. I don't know if I mentioned this the other night or not, but just a couple days ago, we got a call for an infant not breathing, 5-month-old not breathing. And we went down there, screamed down there, and scooped up the baby. Mom's there, grandma's there. And they said, yeah, she wasn't breathing, and then now she is breathing. And so I pick her up and I put her in that cradle position on my arm, kind of like we do for CPR, right? And I start looking at her mouth, and she's moving around. She has movements, and her color's good. And so I'm not so worried about her choking, but I did a few back slaps just to make sure nothing in there. And she had eaten hours before that, had been burped. There was no issues with that. Shouldn't have been any issues with food. And she was, she's 5 months. She's not grabbing a whole lot of stuff and putting it in her mouth just yet. She's kind of, she's being held all the time. So I keep holding her, and I'm looking at her, and I'm trying to, for a second, I want to see her eyes, want to see what her eyes are doing. right? So I'm doing my assessment. Okay. I've determined that she is still breathing. She has an open airway. She has good chest rise and fall. She's, again, if she's doing that, she has circulation. So she has a pulse, and she's moving around, moving all her arms and legs and everything. Well, I want to see her eyes. So I try to open her eyes, and I know she's never opened her eyes yet. So it concerned me. So I try to pry her eyes open. I can't pry her eyes open. I mean, my grown man hand, I can't take this 5-month-old's eyelids and open them at all. And so, as I start looking at that, and I go, this is probably a seizure. And so right about the time I said that, she starts sticking her tongue out, and literally her tongue is almost stiff, and she's rolling her tongue out in front of her. Okay. That's not normal for babies. A little bit of, when they're eating and things like that, to move their tongue in and out, but to have their tongue sticking out for an extended period of time and be more rigid like that, that told me that she's more than likely having a seizure. She was warm to the touch, but I didn't have the ability to take her temperature at the moment. And so I just, when the ambulance got there, gave that report of, all those vital signs, all the vitals, appear to be in place. And she ate, her last oral intake was this long ago. She doesn't take any real medicine. She hasn't had any history of seizures in the last 5 months. She hasn't had any other medical problems, right? So, no, and the events leading up to it were that she was just, being held and things like that. So, but, what the caveat that I threw in there was that, this is what I noticed. I noticed that she was, some of her body movements, her eyes won't open, and she's sticking her tongue out, and she's kind of warm to the touch. So when we start again adding up 1, 2, 3, 4 signs and symptoms, we can start to kind of go down a path, right? Again, she's 5 months old. She doesn't have a lot of propensity for all of these bad things that we as adults have accumulated, in our lifetime. So, the things that could be going on with her, the list is fairly short for a healthy baby like that. And so no other medical issues, no medicines, that sort of stuff. And so that was one of the things that we that's the path that I took, and went down, was febrile seizure. Haven't confirmed that yet. I haven't talked to the paramedic that took her, but I have a strong feeling that that's probably the case. So anyway, don't be intimidated by infants and babies and all that sort of stuff. Just make sure that you're holding them firmly in your hand and your arms and stuff like that. And again, we're doing the same thing. They're not going to talk to you, obviously, so we have to kind of talk to mom, talk to the caregiver, and make sure we get a good understanding of what happened before, what's been going on, any history with them, and then we can start, working our way down. But again, making sure those ABCs are good, and we can start working our way down that checklist. So absent seizures, like I said before, those where, again, like I said, it's kind of brief, momentary. They kind of, like I said, are staring off into space. They might, you're kind of panting heavily. Sometimes they'll do like just small jerks, almost like little ticks or something like that. So, excuse me. And they may come, like I said, they may kind of come back around momentarily. So they may not just pass all the way out. So, for those of you who follow EMS stuff out, there was an ambulance. There was an EMT that was driving an ambulance on the coast not too long ago, several months ago, and was all over the road and everything else. And come to find out, more than likely, she was actually having like an absent seizure. So she wasn't completely out and unconscious. She didn't wreck, but she was actually all the way across the road. She had run some people off the road, and it had a patient and a paramedic in the back. and they end up like pulling them over, making them stop, and everything else. And they actually charged her. Again, we're not going to get on the legal stuff, but they charged her with DUI, and but they never did any DUI tests. So unfortunately, law enforcement may have kind of done the wrong thing there potentially. I don't know. I haven't seen all the facts, but it's one of those things where, according to her neurologist, apparently she had some type of seizure, mild seizure, that caused her to kind of blank out and almost wreck. So again, with those, again, not a whole lot we can do for it. Big thing is we're going to monitor the patient's airway. That's one of the big ones, and arrange for transport. But those the other big thing is just protecting them from themselves, especially the ones that are in full seizure. So they can really flail around, and just their arm maybe bang, or leg or something like that, maybe going back and forth on the ground, or their head, or something of that nature. And we just really want to make sure that we kind of put a pillow under them, or try to we're not just trying to like put them in an arm bar, but we're kind of hold their arm back, so we may have to sit there and let them shake in our arm in our hands almost, but just making sure that their arm's not hitting that wall or bed frame or whatever. So we may have to move them a little bit to try to get them away from some of that stuff. Again, seizures can be from epilepsy, so it could be caused from really flashing lights and changes in temperature and all sorts of different stuff. Trauma, like I said, head injury, stroke, shock, any number of things that can cause seizures. Like I said before, decreased level of oxygen to the brain, high fever, infection, poisoning, overdose, drugs or alcohol. So you could definitely have a drug or alcohol-induced seizure. Usually takes a pretty good bit to do that, or usually if it's a lot of alcohol or drugs in a young person, that may also do it. Brain tumor infection, so something is taking the place, pushing against the brain, so maybe like a brain bleed or something like that, like we talked about in trauma. You could have that abnormality that's going on in the brain, whether it's a mass or blood as a mass that's pushing against, taking the place of, and causing that hemisphere of the brain to react abnormally and causing a seizure. Complications of pregnancy, that's also something to think about. If you have somebody who has complications with a pregnancy, you could potentially have some type of seizure as well. And so you just have to kind of, and usually it comes along with ectopic pregnancies and some of these other serious type of pregnancy issues that the mother is having, and they're usually going to have some type of side effects from that, and seizures are just potential for that. Again, once they come out of their seizure and they're in that postictal state, again, just try to keep them comfortable. They may wake up to a room full of strangers. Okay, so be prepared for that, for them to be scared all of a sudden, to open their eyes and see all these people sitting in their bed, or at their window of their vehicle, or in the store, wherever they're at school, whatever it might be, and all of a sudden have all these people around them. So just be prepared for that. Be prepared to comfort that patient and let them know that everything's okay. You're with the fire department, the ambulance, or law enforcement, whatever it is. Obviously, if for some reason they stop breathing or have some type of airway issue, we want to try to mitigate that as soon as possible. So, it says, you'll find it helpful to be knowledgeable about some of the more specific medical conditions you may encounter. And that's what I was getting at earlier is, your education doesn't need to stop after this class. This is not all inclusive. So, like I said, even as an EMT, and I had a lot of higher level of training or whatever, um, as a medic and stuff like that in the military. And so, I asked questions. I stood by the back of the ambulance or the side door of the ambulance and asked questions and asked to help and all that sort of stuff, and really tried to learn some more, even though I couldn't do anything with the information. I couldn't, in the field, I couldn't start IVs, or I couldn't, couldn't intubate people, and I couldn't, give all these medicines and stuff like that. But I was asking the questions and I knew what was coming next, right? I knew what the paramedic was looking for. And so that's a huge help, whenever you have a really bad patient, but sick patient, very traumatic patient, or multiple patients, especially, then, having somebody that really understands a little bit more than just how to do a patient assessment is key. So the more you know, the more you can do. And like I said, it doesn't always have to be the full on invasive stuff that you're doing, but just knowing that information and knowing what's going to come next is a huge thing. So heart conditions, the numerous types of things. We're not going to get into every little thing. Majority of it, like I told you before, is something electrical or something mechanical. So we have the electronic part of the heart that actually fires the heart back and forth. And then we have the actual mechanical part, which is, the pump part of it, and the pipes. So sometimes the pipes are clogged up. Sometimes the brain tells the pipes to constrict or not to constrict. And so we have problems with that. So neurologic issues. And then, and we have just, again, ate too many cheeseburgers and had a poor lifestyle. And so we have a lot of fat buildup, arteriosclerosis, things of that nature that build up in the arteries and all that sort of stuff, and reduces the flow. Excuse me. So the heart needs that oxygen. We know that we need a good, healthy supply of blood, oxygenated blood to the heart. And so as that as the pump, the heart as a pump pumps that blood out to all the rest of the body, it also takes a little bit for itself. Okay, so through the coronary arteries, and the coronary arteries help to supply the actual heart itself with the tissue and the fibers and all the muscle, the actual muscle, because the heart is a muscle. So all that, just so it needs that good oxygenated blood as well to help it function properly. So it talks about in that last part there, it says progressive arteriosclerosis can cause angina pectoris, heart attack, and cardiac arrest. Angina pectoris is essentially just that the heart is not getting that. That's usually at a smaller level, so some of the little smaller vessels aren't getting that, and so you have kind of like little, a little bit less pain than a heart attack. Kind of little small tinges here and there, little little sharp pains, and that would be angina. So remember, heart attack and cardiac arrest are two different things. Okay, a heart attack is where we have some type of blockage or some type of issue with a vessel that's not getting blood flow, not allowing blood flow to the heart. But their patient is typically conscious and that sort of thing. Okay, cardiac arrest is like we talked about in CPR, is where the patient does not have a pulse. Okay, the heart is not functioning appropriately, and they're not breathing. Okay, no pulse, no breathing is cardiac arrest. A heart attack is simply a blockage of some type. Typically, the patient is awake. Okay. So again, that chest pain caused by inadequate flow of blood and oxygen to the heart muscle is generally what we refer to as angina. A lot of times it's just on a little bit smaller scale, the smaller vessels that are impacted. Shortness of breath, sweating, extremely frightened and has a sense of doom. Again, all those things are also what you hear about with with heart attack. So it's important to that you understand that that's kind of just a general. Those are general signs and symptoms that you may encounter with cardiac issues, and as a whole. And don't just always assign those to angina. Typically, angina is less painful, less debilitating. So it may have mild shortness of breath, mild chest pain, and a heart attack is probably going to have severe shortness of breath, severe chest pain. Again, cool, clammy, diaphoretic, sweating, all that. So again, we do this, and we try to get that patient history right with the sample, and we ask them about past medical history, and if they tell you they do have angina or they have some heart issues before, that'd be one of those things. Have you ever had angina? Have you ever had a heart attack? Right. So if they're complaining of chest pain and they're short of breath, that's obviously a pretty consistent question we want to make sure we ask. Right. And if they do, we ask them if they have nitroglycerin. Nitroglycerin helps to expand the blood vessels so that we get some more, to try to open those blood vessels up and have some more blood flow through there. And that's essentially what we are doing with nitroglycerin. So if they have their own nitroglycerin, that's great. We are not going to carry nitroglycerin to give to them. Okay, that's that would be an EMT skill, but we can assist them with that. So if they are having chest pain, they're in discomfort, we're not going to say, okay, Mr. Smith, if you could just stand up with your chest pain and go walk to the bathroom and go get your nitroglycerin and come back. No, we're going to have them sit there, keep them in a position of comfort, and we may help, like, okay, how many pills you normally take? Just one? Okay, we take one pill and I'll put it under your tongue, right? And we'll hand it to them, and they should already know how to do that or when to do that. If they've been prescribed it, it's their medicine. It's in date, and it's not doesn't look like it's all about to fall apart, because that's why nitroglycerin comes in a little bit tiny bottle that's brown and dark, so that the sun and light doesn't deteriorate it. Okay, it's pretty susceptible to light. So if it looks like it's about to fall apart and it's out of date and all this other stuff, we're not going to give it to them. All right, it's probably not going to have very good effect anyway. So sometimes they'll have a spray, an aerosol spray. And again, it may be one pill under the tongue, let it dissolve, tastes like crap, it's nasty. Or they may have spray. So you may have to find the spray, pop the top of the spray, give it to them, and then let them administer it to themselves. So about 5 minutes or so goes by. We want to make sure that we are kind of notating what they've done. Okay, he took one nitro at this time. Okay, we always want to notate that, how much, what the dose was, and then at what time. And if the pain still hasn't subsided after 5 minutes, let them take another one. The thing with nitroglycerin is that it will open the vessels, but it also speed up the heart rate. Okay, so we don't want to speed up their heart rate so fast, and so we're not going to just give them a bunch of doses. Okay, so if the pain hasn't lessened after 5 minutes of the second dose, assume the patient is having a heart attack and transport them promptly. Okay, we're not going to just keep giving them that nitro. All right, so two doses over the course of about 5 minutes, and then and make sure that we're annotating those dosages and times. So the heart attack, like I said, is a partial or complete blockage of the one or more of the coronary arteries. So as you can see there on the picture, where it kind of descends down from the larger vessels, and helps those little branches on there help to supply the heart muscle. So when the heart muscle doesn't get that oxygenated blood, because it's blocked or whatever, then we have tissue death, so heart tissue death. So when we have that tissue death, then the heart can't pump right. Okay, it slows down, or it just it breaks down and can't, and the muscle doesn't function right. Okay, so if you don't drink water, you don't stretch, you don't do what you're supposed to do, and everything else, your legs don't run as fast, or you can't pump as much, weights with your, doing curls or something, right? So so it's the same thing with the heart. If the heart doesn't get all the nutrients it needs and the oxygen and all that other stuff, it just can't perform correctly. So it's one of those things where we have to try to recognize that, quickly, and generally that, hey, I'm having chest pain, cool, clammy, diaphoretic. Maybe their color is a little off or is off, and we need to try to get them some help pretty quick. Okay. So signs of a heart attack, like we just mentioned several of those, usually severe pain. A lot of times it's going to be pretty high on that 1 to 10 scale, and it's going to be consistent. And a lot of times they'll say like it feels like an elephant sitting on their chest. They're going to be short of breath. They're not going to be able to take full breaths. Sometimes they have that radiation. We mentioned that when we talked about pain, right? So the radiating down up to the jaw, down the arm, the left arm typically, and weak. Sometimes they may vomit or feel nauseous. So those are some of the big signs and symptoms. You need to make sure that you remember those. Those are very indicative of a serious cardiac event. And again, you're not going to be able to know which coronary artery. That you can kind of get pretty close with a 12 lead EKG, but usually like the 3 lead EKG is not going to tell you a whole lot. But once you get them on the 12 lead, a lot of times it'll look at a lot of different angles of the heart, and you'll be able to see that. But if it's blocked completely, or if it's one of the major vessels, so one of the larger vessels is blocked, then you're pretty much going to start spiraling down pretty quickly. If one of those major areas is blocked, the heart's just not going to tolerate it, and it's going to start. It has a high potential to stop. Okay. So again, that complete cessation of a heartbeat is called cardiac arrest. And again, we already know how to do CPR, and that's what we're going to do. If the heart stops, we're going to go right into our, quick look, listen, and feel, check for a pulse, do a pulse, not breathing, because shortly after the heart stops, they're not going to be breathing. Even so, they're not going to be breathing well enough, and you're probably going to start to see that agonal respirations. Again, like we talked about in CPR, just random breathing every few seconds, things like that. And eventually it'll just stop. So we need to get on the bag valve mask. We need to get on compressions pretty quick. And if that is the case, AED may help. Either way, we're going to hook it up and we're going to let it take a shot and see if it does. If it does, that's great. If not, we're going to continue with our CPR. 30 compressions, 2 ventilations, and we're going to do our multiple cycles, reassess, and keep doing that like we talked about in CPR over and over again until we get a higher level of care there. So if they are having a heart attack and we're able to kind of work with them a little bit, they're alert, again, they're going to be in a lot of pain. So it's just one of those things we have to kind of work with it, try to put them in the most comfortable position we can. Usually sitting up is usually pretty good. And we can, if they have it available, again, same thing, we are assisting. Okay, we are assisting with all these things. So the nitroglycerin, the aspirin, a lot of these, medicines and stuff, we are only assisting. We are just basically helping open the bottle, put it in their hand, that sort of thing. Okay, if we need to maybe coach them as to putting that nitroglycerin under their tongue, or telling them to chew these aspirin up. Okay, chew them up and help that absorption rate a little bit more. So help the patient take 1 adult aspirin or 2 to 4 low dose or baby, what they refer to as baby aspirin. Somebody may already have those and be on an aspirin regimen from their doctor. And if that's the case, if they have it available and, they're meeting all this criteria, they have all this going on, these signs and symptoms, then, may just have to suggest it to them. Yeah, it's over there on the shelf. Grab 1 adult aspirin, tell them to chew it up and swallow it. They don't need a lot to drink. They don't need anything to eat. Okay. We don't need, they're more than likely going to go to a cath lab or something like that pretty fast, catheterization lab. And so it's important that they don't have a whole lot on their stomach. So administer oxygen if it's available, high flow to, non-rebreather, 15 liters per minute. Excuse me. If we do end up having a bag valve mask for assisted ventilations, if they're in cardiac arrest, then obviously we're going to use 25 liters per minute for our bag valve mask. But if we're just using our non-rebreather mask, 15 liters, high flow O2, and try to help out that oxygenation of the body as best we can. Tell them big deep breaths with that. Sometimes it helps their anxiety come down. We can also try to work them through some breathing techniques to help calm them down, and which will kind of lower their heart rate, lowers their blood pressure, so we can kind of help them help themselves. Okay. All right, going into congestive heart failure, or CHF. CHF is not fun for your patient. Essentially, they're almost the heart is almost drowning in fluid from the inside out. So it's it's a failure of the heart to pump adequately. So if there is issues with the heart long term usually, and one side of the heart won't pump correctly, and so that side of the heart starts to take on fluid, and once it does that, you have a congestion in those blood vessels. And so again, it's just like we talked about with those alveoli having fluid in there, and it is almost like if you put them underwater, they just wouldn't be able to pass air back and forth. Okay, so that's the same thing. So now we can't put blood back and forth through these vessels. Big sign here is going to be breathing difficulty. That's going to be one of your main signs, and they're usually have like some type of wet type gurgling respirations. So as they're breathing in and out, instead of just you're going to have an audible like it's going to sound wet. So because of that, usually rapid shallow breathing, profuse sweating, enlarged neck veins. So again, that backup essentially is taking place. It's backing up into the system, and so those neck veins are going to start to get distended. So we call that distended neck veins. Okay. And obviously that's the jugular. So jugular vein distension, or JVD. So if you ever see it JVD, that's jugular vein distension. Okay. Swollen ankles, again, the systemically down into the lower, more distal parts of our body, we're going to experience that system back up as well. And then just because of gravity, you're going to have some of that fluid build up in the lower ankles and things of that nature. So again, not being able to breathe very well, you're going to be pretty anxious. So that's why we try to get them to slow their breathing down and try to make the most of their breathing. So anytime we have this, we want to have our patient in the seated position. Usually they're going to want to sit up as straight as possible. May even have to kind of push them over a little bit and hold, keep them in that upright position. and let their legs dangle, so some of that fluid can try to go back into the lower parts of the body. And again, administer oxygen in large quantities and at a high flow rate. Some of what this does is help to try to push some of that fluid back where it needs to go. And but also, again, like I said, the heart's not pumping well enough, so we really want to have a good reoxygenation. Obviously, we're going to need more help with this. It's going to be an ALS transport. They're going to need to do several different things for them. Excuse me. And so that's something we definitely want some help for. On the other side, it is dyspnea. Dyspnea is just another word for shortness of breath or difficulty breathing. Again, it could be from several different things, but a lot of times it's the same shortness of breath we talked about when we talked about some of these heart-related issues, heart attack, CHF. That's essentially what that is. So the breathing part of that is dyspnea. So whenever you say, oh yeah, they're having chest pain and they're having difficulty breathing, short labored breathing or short rapid breathing or something like that, that's dyspnea. Okay. Again, other causes could be that pulmonary disease, COPD, emphysema, bronchitis, pneumonia, asthma, any of these things. So dyspnea is kind of just a general term for any type of difficulty breathing. Obviously, anytime we encounter the patient for the first time, we just want to make sure that their airway is patent and that they don't have an actual airway problem. So there's nothing stuck in the airway causing that dyspnea, and making sure we check that rate and quality. So is it rapid? Is it deep? Is it slow and labored? Is it really hard to get a breath out? Any of those types of things. We want to notate those. The other thing, again, like I said before, like we just mentioned, is reassurance. Try to keep them calm, slow their breathing down, and try to, again, make the most out of their breathing. Again, if we have oxygen, we'll try to do that as often as possible with our breathing, with our dyspnea type patients. We want to have try to have some oxygen on hand and give them at least a non-rebreather mask. So with asthmatic patients, it's typically like an acute spasm of the bronchioles, and sometimes it could be some buildup of mucus in there. So essentially the lining of that respiratory passage is irritated, and it starts to swell, and so generally it just, like I said, so the air just can't pass through all those small airways down in there, and it can't exchange gases and all that stuff. So asthma sometimes is acute. I mean, the actual act of